lunchtime. Want to enjoy your lovely, very good lunch. Thank you, Danielle, for coming and to your team. So they asked me to talk about skin cancers, and I think this is the right place to talk about skin cancer. I mean, it is a white person's problem, predominantly skin cancers, because they moved from the north of the world closer to the equator, and the ultraviolet radiation in the sun was not ready for that, or they were not ready for the ultraviolet radiation. So the more you move down south toward the equator, higher exposure to ultraviolet rays and more incidence of skin cancer. So no surprise, as Florida keeps becoming the more populated state because everybody wants to move down south, you do have more incidence of skin cancer. So we'll talk about different skin cancers, but this is the most common reason, all because of the ultraviolet radiation from the sunlight. And where in the 40s, when they made tan skin a very attractive thing on the media, and everybody jumped to be more tan out there in the sun, and if you're a little bit tan on your skin, you are more considered more attractive. If you really look back in your paintings from the 1800s, you will see women on the beach holding umbrellas and fully covered. They were the more affluent one, and poor people used to work outside, so they were the tan one. And when the Industrial Revolution came, everybody was indoor, very few people were outdoor. So now everybody was fair skinned. So now the rich people started to go on vacation on the beaches and come back with a tan skin. Now that was a symbol of status symbol. So other people tried to copy it as much. And so in this cycle of trying to look more attractive and or just not worry about the sun. Sun has benefits. It has vitamin D, which is good for our bones, but the damage which it causes to the skin, that's what leads to the skin cancer simply. So it's predominantly, it's increasing, incidence is increasing all over the world for skin cancer. And we are going to talk about 3 skin cancers, and the top 2 skin cancers are called non-melanoma skin cancers. And obviously the third one is called melanoma skin cancer. So these are treated and discussed differently, and this is a different disease process as compared to the first 2 ones. If you have any questions anytime, you can ask me. Basically, the skin has 3 layers. The epidermis is the topmost layer of the skin. Under the epidermis, that's a thin layer, and there's a basement membrane, and then there's a dermis layer under it. Most of these cancers start in the dermis layer, and then they kind of move upward, and they can ulcerate the epidermis, so they start from inside out rather than outside in. Most of these, but the damage usually is first sustained in the lower layer, the dermis layer of the skin. So let's talk about the basal cell cancer. In the United States, estimated 4 million cases of basal cell cancer. Now you can have a patient or a person who may have 2 times or 3 times, so there's not that many people, but that many cases every year on average are recorded for basal cell cancer. So you may have about 2.5 million people who have basal cell cancer. We already talked about the white population because their skin was not naturally evolved to take the sunlight or the damage from the sunlight. They didn't have the natural protection as a part of evolution as we, the darker skinned people, have. We have a little bit more melanin, a little bit more protection from the sun damage. They say about lifetime risk is about 30% in white population, men more common than women. And as you move closer towards the equator, the incidence and the sun like has more ultraviolet radiation. So when you say closer to equator, like Minnesota will have less chances compared to Arizona or California. Because that's when on the globe you go down south towards the equator, the higher the incidence of this would be.
Doc, why would men have more common than women?
Oh, I think still we have that generation where men were boys, were more outside. So most of this happened when you, before age, say 18 or 20, when you're out there in the sun, you had those intense sunburn. And traditionally, in your age group.
Well, what I think of is these young ladies in their bathing suits out tanning.
And we will see those effects 20, 30 years from now. So the sunburns happen when you were young. The results happen like 30 years later, 40 years later. So this damage was done at a younger age. So in your age group, boys were more likely to be outside. And so we see that, but the trend will change. Just like in lung cancer, men used to have more lung cancer than women do. But in the 70s or 60s, women started smoking because they started to go to work. So by 90s, the incidence of lung cancer increased significantly in women because they started smoking in the 60s. So the effects were seen later on, 20, 30 years later.
May I interrupt?
Oh, anytime, sure.
I have vitiligo, so I'm losing my pigment. Does that make me more prone to skin cancer?
So theoretically, yes, but the problem is this happens in so few people that we can't have a large population study, because if we do that, we will have 5 patients versus 3,000 people. So we can't really make a good clinical trial, but theoretically, yes. And then secondly, people who have this pigmentation problem, they suddenly also become more conscious and they're less likely to be out there in the sun damaging their skin. So they suddenly realize that, they have to be more protective of it. These things happen when you didn't think about it. This damage happened when you think that you're invincible, nothing can get you. You can be out there in the sun and you're just made of steel, and that's when this thing happened. But once you have any skin condition, people become very conscious, and so they're very protective of it. So you can't just develop it at this point of life, because this is usually from the damage from many, many years ago. Australia has a big hole of what? Atmospheric ozone hole. And so that filters the ultraviolet radiation. And that's why they stop allowing people to use certain chemicals which may cause damage to the ozone in the atmosphere. And I remember when I was trying to put some stuff on changing the air conditioner, or some that liquid in the air conditioner, that were very restricted, because all these environmental things we do can damage the ozone layer. Ozone is a filter for ultraviolet radiation. So Australia has highest incidence of skin cancer and melanoma, which are from ultraviolet radiation. So it's very important that we try to protect our atmosphere and try to maintain the ozone layer.
Doc, are you saying that once we have skin cancer, we're more likely to have it again?
Yes. Studies have shown that a person who had a skin cancer is more prone to develop another skin cancer in their lifetime than those who never had a skin cancer.
Well, are they, I had a place come up on my elbow.
Mm-hmm.
I had it removed
Mm-hmm.
3 times in a row. And the last time it said, there's cancer cells there.
Right.
So now then I've had complete surgery, removed all the skin from the elbow and have new skin there, and I've never had any problem.
Right.
I went through everything I was supposed to.
Right.
But it said, it was showed cancer. It's the last time I had it removed 3 times.
Right. So what you're saying is, I mean, are you more prone to have high risk for developing more skin cancer? The answer, your dermatologist is probably telling you, you need to follow up with us for pretty much
Well, it's
every
been a
few
long
months.
time, and I've been
Yes, you have to just keep
around.
doing that, because those patients who had one cancer, they are prone to developing or showing another skin cancer. So the incidence is higher in older people. Of course, that's natural because it takes years for that damage to translate into skin cancer. So we talked about ultraviolet radiation, sunlight. We should talk about the tanning beds are equally bad. They do the same thing in a more focused environment. So people lying in a tanning bed, they are basically being bombed with the same ultraviolet radiation. So tanning beds are bad and they serve no good purpose in society. So I think they should be banned.
Come on, so hold back.
There's no Second Amendment right to tanning beds, so it is not. The phototherapy are certain kind of treatments given to patients for other skin conditions, like for psoriasis. Those are called phototherapies. They can also increase, unfortunately, those treatments can have a side effect. They can increase the risk of these skin cancer, like basal cell cancer. And certain radiation treatment given to children in the younger age can also increase the risk of skin cancers, because we have seen in children who get radiation for certain cancers or other problems, when they grow up, I mean, in that area radiation field, there's a higher incidence of skin cancer. So that also is a risk factor, and there's certain hereditary risk factor. And finally, immunosuppression. Patients who are who have organ transplant, like a liver transplant or a kidney transplant, they are given immune suppressant drugs so that the body does not reject the liver or the kidney. Those patients are high risk for developing skin cancer, because normally our immune system keeps these things in check. Your immune system, and the cancer cells are forming, that tries to fight it. But if you suppress your immune system with medicines, which you have to do to protect the organ transplant, that can increase the risk of basal cell cancer. So there are different types of basal cell cancer. I'm going to show you a few images. So the most common of the basal cell cancer is what we call a nodular. It's like a nodule under the skin. It's a little bump under the skin, and it can become ulcerated. So very commonly patients will come and show, see, what does this look like? And that typically would be a basal cell cancer. So you can see it's like a little bump, and then the center of that becomes ulcerated most of the time. This is the most common kind of a basal cell cancer. Now, one thing about basal cell cancer, basal with a B, is it does not spread to other organs. This is one cancer which will not spread to the lymph nodes or to liver, lung, brain. So that's a good thing. It is unlikely to kill the person, but it can grow invasive. It can dig deep in the skin and become a very ugly ulcer on the body. But since it's an invasive species, we call it a cancer. Because some people argue, if it doesn't spread, should it be a cancer? Well, if it's an invasive species which can grow unhindered deep into the tissue, we call it a cancer. So the most common one would look like this. And the other ones which are more also seen are the superficial one. These are superficial ones. They don't have that big nodule under it, but irregular margins and some irregular growth, and they could come in different sizes and shapes. It could be as big, like this is all a skin cancer. See how big, it's pretty big size. So this can locally grow in like a weed in that area. But they will most commonly be on the, sorry to show this picture in the lunch hour, but this is on somebody's nose. This is the nose. So left unattended, it can continue to grow and really disfigure the whole part of that organ. So most commonly these would be on the area exposed to the sun. And so, especially children who are usually stay home, be good kids, but then they go out on that beach vacation, which has become very fashionable, to go to Florida, and they come home with those sunburns at a young age. That's intense sunburn is what increases the risk. But so typically children would be out, the boys would probably be wearing shorts only, so that would be exposed area, could be his arm, face, back, the trunk, and girls would be probably have swimsuits, so that still would expose significant amount of body. And so those areas which get those intense sunburn at a young age, those are the ones which are at risk for basal cell cancer. So the bad news is that most of you can't really do very much for yourself anymore, but you can at least tell your grandkids, your children, that they are harboring skin cancers when they go out and get sunburns.
So these kids that are out playing baseball all the time are in really danger.
I thought they wear pants and everything in baseball.
But yeah, but their face isn't.
Yeah, well, they still wear baseball caps.
Oh, okay.
So if my daughter got a really bad sunburn when she was about 10.
Yes, she is a risk for developing skin.
Now she's 50, she hasn't.
Right, I'm not saying everybody will get it, but those are the ones which increase the risk. Again, remember, constantly your immune system is also fighting on the side of the patient against these cancer cells. So it's trying to control the development of cancer, but those are the ones which are at risk for the sunburns, which are at risk for developing this skin cancer later on. But, you know, these, like.
This many years that she had?
Yeah, it can be in the 60s and 70s when this balance between the cancer cells trying to come up and then your immune system kind of gets tired of fighting it and backs off, and then those cancer cells, they start popping up. So we see that commonly people in their 70s, but the damage was done when they were in their 20s or teens. But the skin cancer shows up in the 70s and 80s at that time, when the balance changes between the two. You can see somebody's whole ear basically had a cancer. So these basal cell cancers can be destructive. The edges are usually rolled in, and so most physicians who do this for a living, like dermatologists, can usually look at it and tell you, yeah, it looks like a cancer to me, but still most of them will do a biopsy before they will decide to remove it. If we do sun protection before age 18, your grandchildren, you can significantly reduce the risk of skin cancer. So this is an investment in the future. I know, it's very easy to tell a 16-year-old don't do that. I know. I have a 16-year-old and 13-year-old, so. Sunscreen is protective. There have been some studies where the Celebrex makes a difference. One study showed that it probably does. The other study showed it probably doesn't. So I think there's probably more damage from Celebrex would be than there would be protection. And vitamin B3 is shown to be somewhat protective of skin cancer. And sometimes in very high-risk patients, this is like a chemo thing with the topical chemo, but usually these would be used in people who had bone marrow organ transplants and are on immunosuppressive drugs, or certain high-risk HIV patient population. So not for general population, not recommended for your grandkids to use.
I really am trying to listen, but what did you say about Celebrex?
It has more damage. It can hurt your kidneys, can hurt your stomach, can cause heart attack, can cause a stroke, but it may protect the skin cancer.
Oh.
It's not a good trade-off. There are many ways to treat it, but the most appropriate way to treat is to remove it by surgery, simply by cutting that part of the skin out. Thank God we all have plenty of extra skin when we are, especially when we cross 50s, so they can easily patch it up and remove that part of the cancer. That's the easiest way to treat basal cell cancer. Sometimes you can do curettage and electrodissection, which is, this desiccation is where they, it's like, you know, we all have that ice cream, big bowl of ice cream which is frozen, and we want to eat it, and we get this spoon and we try to take a little bit piece out because hard, like a rock, right? That's called curettage. It's like to slowly remove little piece by piece. So that can be done on these kind of skin cancer. And there are many other treatment options available for patients who are not good candidate for surgery. Sometimes it's in an area, for example, in an eyelid area where doing surgery will be a little bit difficult. It's not uncommon for people to get skin cancers in this area. So it's not easy to remove the eyelid. So in those cases, sometimes we can do other treatments like photodynamic therapy, radiation. Sometimes we can inject stuff inside the cancer, and that can also kill the cancer. These drugs have a lot of side effects, hedgehog inhibitors, but they are also effective in controlling cancer in some patients. And the newest treatment is immunotherapy. Remember when I said your immune system is constantly fighting the cancer in the body, but it gets tired after many years and it doesn't do it? These immunotherapy drugs, they enhance your immune system to attack the cancer cells so that basically your own body is fighting it again. It's kind of putting new tires on an old car. I mean, it's just gonna, or new engine in an old car. It's just gonna go back and fight again. But when you do that to the immune system, it also has potential side effects because it can also attack normal organs. So we only use it in patients who really have more advanced disease and can't do big surgery or not responding to surgery or keeps coming back after surgery. That's when we can use immunotherapy in those patients.
Where's the name hedgehog inhibitor come from?
Hedgehog pathway is one of the pathways of this development of these cancer cells. So inhibiting that pathway is one of the drugs. But since we had immunotherapy treatment, I don't think anybody really uses those because the side effects were significant.
What kind of medicine or drugs are the immunotherapy?
These are the immunotherapy drugs. We give these as an IV drugs. Like the only one approved for this is the brand name is Libtayo. Cemiplimab is the name, the correct name of the drug. So basically, they're given as an IV infusion, and it's like once every 3 weeks. They don't have any side effects like hair loss or nausea, vomiting, or anything like that. But they can have an immune-related side effects rarely. Generally very safe and easy for patients to take, and can be very expensive as well. Right, Johnny? Yeah. So Johnny has to write the bills for them. All right, we're going to talk about the other kind of cancer called the squamous cell cancer. These are not melanoma cancers, but they are a step uglier than the basal cell. The basal cells are the ones which do not spread. Bad news, squamous cell cancer also are a similar type of skin cancer, but they have a tendency to spread and they can become resistant. Squamous cell cancers also happen or occur inside the body like in the lung cancers or in the oral cavity cancers or cervical cancers are also squamous cell cancer. But these are the ones which we are talking about are primarily the skin cancers, the squamous cell of the skin. Again, as we go south, the incidence increases of these cancers. Looks like a rerun of the same slide which we talked before. Ultraviolet radiation. This one is more cumulative sun exposure. So like every day out, that farmer who goes out every day and does not, well, most of our farmers usually will have normal protection, and many still would used to wear hats and still wear hats or caps, so they will have some facial protection and some skin protection. But this is unlike when I said the previous one was that burned at before age 18. This one is like slow build up. Every day you go out in the sun, work in the yard or anything, that increases the risk of squamous cell cancer. And again, arsenic exposure, which is in certain fertilizers around the world, can increase the risk. Family history, organ transplant, much more common. We see that in patients who had kidney transplant, liver transplant, they're on immune suppressant drugs, and a few years later they'll have the skin cancers popping up. And some of I knew many patients with organ transplant, you stop their immune system drug, immune suppression drug, skin cancer gets better, but the organ becomes a little risky, so they risk either losing their new kidney or their kidney donated to them, or they risk with the skin cancer. So it could be a very tight situation for a patient to make a decision. Certain drugs can also increase the risk of squamous cell cancer, especially the one which possibly can thiazide. This is a very common treatment for blood pressure. It's a water pill in many blood pressure treatments. I'm not saying that it should not be used, but patients who are at risk for squamous cell cancer will have to think twice and see, because this adds to the risk of this squamous cell cancer. So somebody who's had an organ transplant or is immunosuppressed, or somebody who's HIV positive, I mean, these medicines can further increase their risk. This is an antifungal treatment, and this is one of the cancer treatment drugs. We divide the squamous cell cancer into 3 risk categories. I have 2 listed here: low risk and high risk. And the third one is very high risk. So the low risk are the ones which are less than 2 centimeter, 2.6 centimeter make 1 inch. So it's little 2/3 of an inch, less than 2/3 of an inch. They're on the trunk or extremities, low risk. And when the pathologist looks at it, he says it's well differentiated, that's a good thing. When it says well differentiated, that's a good thing in squamous cell cancer. And these are not very thick. When they have this specimen, when the surgeon removes it, or the dermatologist removes it and sends it to a pathologist who looks at it, and will see, measure the depth, how deep it is. If it's going deep into the tissue, that's a bad sign. If it's not very deep, that's relatively a good sign. They say less than 6 millimeter and no invasion into the organ. That's a low risk disease. What's a high risk disease? Same thing on the trunk and extremities, but more than 2 centimeter. Anything on the head, neck, hands, feet, in the leg area and in the genital area, that's a high risk disease. Again, remember, extremities would be this, but hands and feet, and these would be high risk area. And then you don't have to worry about the histology thing. That's usually for the physicians to see which one would be high risk for squamous cell cancer. And very high risk is more than 4 centimeter. Remember, 2.5 centimeter make 1 inch, so about 1.5 inches, bigger than 1.5 inches is a high risk. Doesn't matter where it is. High risk for squamous cell cancer. And then this is the histology. The pathologist will say it's a poorly differentiated and it's very thick, or other features. And any patient who is immunosuppressed and had organ transplant, squamous cell cancer, in that patient will be high risk, because we talked about how it is difficult to stop their immune suppressant medicine because their organ would be threatened by that. So you have to keep both in place. The treatment for low risk, again, surgery remains still the main treatment. We like to have some margins around it. Mohs surgery is still a surgery, so the dermatologists who do the Mohs surgery, they have a microscope on patient. For example, if I'm having surgery on my hand, they'll have a microscope and they'll remove little bit piece at a time. And there's a pathologist who will tell and say, once everything is clear, you say, okay, now I can see normal cells. So they don't have to take a big chunk of skin around it. So it's done under microscope, so you can remove minimally. Typically done on the face, because you don't want to create a big hole in the face. You want as little as possible, but you don't want to leave the cancer behind. So the Mohs surgery is done in a very microscope way, and slowly, little bit piece at a time, remove it. And once you have all the margins around it clear and deep inside it is clear, they tell them everything is now normal. So that's called Mohs surgery. This is, we again talked about, very rarely done in this kind of patients. Cryotherapy, cryo means to freeze it, so patients can have liquid nitrogen. These can be frozen. Same thing with the basal cell cancer, it can be frozen. So they can put some liquid nitrogen, freeze it. Freeze sounds like very good, but it's not as good as the ice cream is, because it does cause a lot of burning and irritation of the skin afterwards. So it's literally a burn with the freeze. So, but anything is better than cutting it. So in some areas in early stages it can be done, and those patients where we can't do anything, we always do radiation therapy. High risk disease, same thing, surgery, Mohs surgery. Remember, we don't do freezing and all that stuff anymore here because this is a serious problem. These people, cancer can spread and they die from it. Remember, basal cell cancer doesn't spread. That's the thing, if you take one message home, basal cell cancer doesn't kill, but can disfigure the organ. Squamous cell cancer can spread when it's a high risk disease. So it has to be taken seriously. And I had couple patients where we used the immunotherapy treatment to shrink the tumor and then do surgery, because that makes it easier for the surgeon. So these can be used in certain high risk cases. And we always have to consider radiation therapy sometimes after surgery. Sometimes the surgeon removed it and say, I can't take any more skin off, it's really very tight space here. So then and still there's one margin showing some cancer cells. So we may do a little bit of radiation afterward, but these can spread to the lymph nodes. Lymph glands are the drainage. And so it could go to the lymph node, and if there's a large lymph node removed with the cancer, we may have to do radiation after surgery in these patients. All right, we're gonna talk about melanoma. But any questions so far on these non-melanoma skin cancers? 30% of you will have it in your lifetime, which means 1 out of 3, which means 4 or 5 people in this room will get it during
Your
their lifetime.
autoimmune system.
Huh?
You're talking about if you take something for your autoimmune system, does that make you more susceptible to
You
cancer?
suppress, yes, anything you take to suppress your immune system.
Because I'm taking a shot for eczema, which I understand is
Yeah,
suppresses my immune system.
right, so usually that would increase the risk of squamous cell cancer. What I'm talking about was a real heavy duty immunosuppressants, which are usually done for organ transplant. That's much more heavy duty than the shot for eczema.
But I should be more careful probably.
Yes,
Taking the shot.
right, anything growing on the skin should be addressed with the dermatologist. So, the melanomas are different skin cancers. They also develop because of exposure to that intense sunburn at a very young age. And this is one of the leading cause of death in younger population. Probably the second leading cause of death in the younger population. And what happens is we all have cells in our body, in our skin called melanocyte. People with darker skin have more melanocyte than people with fair skin. They have less melanocyte. So their melanocytes, melanin is a pigment. So when the sun hits our skin, those melanocytes, they secrete or produce that pigment, it turns darker. And people who have lighter skin have their melanocytes are not as active, as robust in controlling that production. So they can try to produce, overproduce, they can become cancerous. So that's why melanoma is also predominantly, what I'm talking about the cutaneous melanoma, melanoma can happen in internal organ as well, and that has nothing to do with the sun damage. So, but we talk about the cutaneous melanoma or skin melanoma. So these cells then, they become cancerous, they can grow, they can spread. About nearly 100,000 new cases of invasive melanoma, which are risk for spreading, and about 100,000 are low risk for spreading. In situ means not invasive cancers can happen. And the incidence amongst the younger population had decreased from 2006 to 2015. People have gotten smarter. Believe me, your children and grandchildren are smarter. And that should be your children. From 2006 to 2015.
Well, they've got those phones to
Phones,
play with.
yes. So good. So one advantage of having phones is they're not outside in the sun. So the incidence decrease in this younger population between these years. So we hope that this will continue to decrease over time. And we still have to remember there are about 9,000 deaths every year in the United States. And most of these are young people. Most, not all, but most are younger people. Melanoma can also happen in the 70s and 80s, but most of the skin melanomas occur at a younger age, typically in the 30s and 40s, and I still know many people, patients in the 30s and 40s who died from melanoma. The good news is that these immune therapy treatments have significantly changed, improved the outcome of melanoma patients. Now, as a trivia question, which famous US politician recently had melanoma which spread to the brain? Jimmy Carter. Yes. Now he went on hospice care, but his melanoma, and actually he's fair skinned, we can tell that. But his melanoma spread to the brain, that was about 7 years ago. With these immunotherapy treatments, not immunosuppressive, with these immunotherapy treatments or immune boosting treatments, they got his melanoma under control for many years, but eventually started to grow back again, and this time they said there's not much they can do, but that's still 7 years is a still significant time to live when the cancer spread to the brain. And so these drugs have really changed or improved the outcome of treatment of this very serious condition. So melanoma usually will present with dark pigment. It could be an ulcer, but usually it's a dark pigment. Remember, melanin producing cells will usually be darker inside. So any mole which people have when they're growing up changes color, changes the border, becomes irregular. That would be high risk for melanoma, so those need to be looked at. Usually they will do a biopsy of that. Biopsy is to take a small little pinch off that spot and look at it with the microscope. So any mole which you had needs to be monitored, and that can be done by a family member or patient can do it themselves, but if it's on the back or somewhere, have your doctor keep track of that, and it's not a bad idea to take a little back selfie once a year and see if it's changing. So if once the border becomes irregular or the shade changes, these would be the signs that a previous mole is becoming melanoma. So you can have that mole for 20 years. That's the first time when your spouse notices, hey, there's a mole there. Yeah, it's been there for a long time. Fine. It can change into melanoma. So just because it's been there for a long time is not a guarantee that it will stay like that. So in a previously existing mole can become melanoma. So any change, keep a map of your moles on the body and keep track of it and see that you can measure how big they are. If they become larger in size, irregular border, and shade change or color change.
Well, what about, you can have them taken off. I've had moles on my neck and things, I had taken off, you know, when I was a young woman, and that was the end of it. So are you talking
Yes.
about a lot more serious? Because I've had several taken off, they would, you know, mow here, mow in the wrong place, and I had it taken off by a doctor, of course.
So I don't know if Medicare
I
pays.
must not be the right thing.
Medicare, yeah, if you take off and it is not cancer, I'm not sure that it's covered by Medicare, it's
Oh,
considered
well, I know,
cosmetic.
this was years ago, I went
Yeah.
to the doctor and he took them off.
Yeah, but it's considered cosmetic then, if it turns out not to be so,
Oh,
a cancer, so sometimes they'll just take a biopsy, just little needle
These are just
biopsy,
removed
if
every-
there's a mole, but,
Different stages of it.
yes, so melanoma, as we saw before, could be non-invasive or invasive. So non-invasive, you don't have to worry about, they remove it, you're done. Invasive melanomas, if they are more than 1 millimeter deep, and 1 millimeter, how big is that? 26 millimeter make 1 inch, so 1/26 of an inch deep. That's very small. Then it is a higher risk for spreading to the lymph nodes. If it's more than 4 millimeter deep, which is 1/6 of an inch, then it's considered a high risk disease. If it's spread to the lymph node, it's a stage 3 disease. If it's spread to other organs, it's a stage 4 disease. So stage 4 is considered a high risk disease with a high risk of patient dying from it. So melanomas have to be taken seriously and monitored. Person who had one melanoma is gonna be at risk for developing another melanoma, so they would have to monitor it for the rest of their life, or the skin check especially having the same practitioner, same dermatologist look at it, or keeping some track of it with some imaging helps them determine if anything is changing or not. So again, the bad culprits are same thing: ultraviolet radiation, sun exposure, intermittent exposure during the childhood, and the tanning bed. So whatever can cause basal cell cancer will cause melanoma. And same risk factors: immune suppression can increase the risk of melanoma. Person who had one melanoma is going to be at increased risk for another melanoma during their lifetime. So that person needs to see a dermatologist pretty much for the rest of their life, because you cannot ignore these things. Other risk factor, fair skin, we already talked about. And nevi is nevus, is a multiple of nevus, which means basically skin, moles, and all that stuff. So those are increased risk of melanoma. Again, just because you had it since you were young does not mean it cannot become melanoma. It can become melanoma. You have to keep track of all those nevi. Treatment for melanoma, skin cancer, like other skin cancers, surgery if possible. Many times if it's spread to the lymph node, or if it's a high risk melanoma, a melanoma which has ulcer on the surface of it, is a bad actor. So those patients usually will need immunotherapy treatment after removing the melanoma. Because why? Because there's a risk that melanoma cells, they have a high tendency to spread to other organs. So they can go to the brain, liver, lung, other places, bones, they can go to the intestine. So if many patients who had it spread to the lymph node, we give them immunotherapy treatment for 1 year after surgery, and that has significantly shown to reduce the chance of it spreading, or if it has spread, of growing or coming back again. Then usually the immune system will take care of it. And then we have targeted treatment. Certain melanomas have certain mutations, like a BRAF mutation, and so there are drugs which can be used in those patients. Those are very few patients, but certainly these are the changes for the stage 4 disease. These are for stage 4 disease, and it's not always curable. Most of these patients unfortunately will die even with the new treatments, but some of them will be cured with these treatments. So there have been advances made, but the biggest advance we can make is use sunscreen, avoid sunburn. These are the biggest advances. So invest today in your grandchildren, children, so that they will have less chance of melanoma. We already are doing it, but we need to create awareness. And because of that awareness, Danielle has arranged for what here?
Their sunscreen and chapstick.
Okay. And these are not melanoma protecting, but these are good. Any question?